around 2 decades ago. The study is very significant considering that there is a very little evidence on what works when it comes up to the scaling of evidence-based intervention in the context of low middle income countries. It's well established that if we want to address the burden of violence against women, that the scaling up approach we have to go on, but very little evidence that what are the approaches or what are the facilitators or the barriers that actually on ground play an important role when it comes up to the scaling of the model. Even if what are the characteristics of a piloted model that can impact the scaling up of the system based interventions. So for today's dissemination seminar, we have with us Professor Surinder Jaswal, who is the Professor and Dean of School of Research Methodology at Tata Institute of Social Sciences. Professor Jaswal holds a doctorate degree in public health from London School of Hygiene and Tropical Medicine, University of London. She was the former deputy director at TIS. Her research interest areas include social work education, public health, public mental health, women's health, violence against women and children, disaster studies, and social science research. Thank you, Professor Surinder, for joining us today's webinar as the chairperson. And then we have our first discussant, Elizabeth Dartnall, who is the Executive Director at Sexual Violence Research Initiative. Liz is the Executive Director at SVRI. She's a health specialist with over more than 2 decades of experience in research and policy making on health systems, mental health, violence against women, and violence against children. Having worked in several countries in both government and research positions, Liz has a deep understanding of the policy process and the use of the research to inform policy practice. Then we have with us Dr. Mary Ellsberg as our second discussant. She is the founding director of Global Women's Institute at George Washington University. Dr. Ellsberg is an American epidemiologist whose research focuses on global health and violence against women. She has more than 30 years of experience in international research and the programs on gender and development. She was a member of the core research team of the WHO multi-country study on domestic violence and the women's health. So a very warm welcome and thank you to the chairperson and both the discussants for joining today's dissemination seminar. We can begin with the presentations from the Sehat team. So the way the presentations from the Sehat team they are conceptualized is that my colleague Anshit will first talk about briefly about the Dilaasa model and the methodology. And then Dinah will talk about the facilitators and the scaling up strategies for the upscaling of Dilaasa. And then I will talk about the opportunities to strengthen the health system's response to violence against women based on the study that we conducted. So I would like to request Anshit to start with the first part, which is about the Dilaasa model and the methodology part of the.
Thank you, Sanjida. Am I audible?
Yes.
Yes.
Yeah. So I'll begin with the Dilaasa model. In India, the Dilaasa model is one of the first health system initiatives to address violence against women. Dilaasa, a public hospital-based department, first established in 2000 with collaboration with Center for Inquiry into Health and Allied Themes and Municipal Corporation of Greater Mumbai. Dilaasa in 2016 was scaled up in 11 public hospitals in Mumbai under National Health Mission. The scaled up Dilaasa department comprises of 2 counselors, 2 auxiliary nurse, midwife, and 1 data entry operator. Dilaasa carries out capacity building of healthcare providers to help them identify cases of violence during clinical inquiry, provide first-line psychological support, and refer to Dilaasa for further support and counseling. At Dilaasa, survivors are informed about service provided at the department. Counselors ensure survivors that the information shared at the department will be kept completely confidential. Consent is taken before carrying out any form of intervention. So, counselors provide survivors about service provided at the Dilaasa Center. They then provide emotional support using feminist approach of counseling, keeping in mind the 4 principles of counseling. In that, they address survivors' guilt or blame of violence, talking about violence as a power issue, respecting women's autonomy, and most importantly, recognizing impact of violence on health. Next, the counselor carries out safety assessment and safety plan for survivors. Here, the counselors ask questions to survivors to assess the severity and frequency of violence. A plan is developed in a participatory manner by explaining the feasibility of options open to her. Next, the counselor provides emergency shelter and explains survivor about provision of 72 hours facility available in the hospital. This is given to survivor in cases where the survivor do not have any safe place to reside. Next is the counselor carries out intersectoral coordination, which includes with the police, with the protection officer, with the child welfare committee, and the shelter home as per need of survivor. About the background of the study, there is an evidence to suggest that health sector model plays a critical role in responding to survivors facing violence. Dilaasa is one such redesigned one-stop center model adopted to local context located within the public hospital in Mumbai. In 2011, an external evaluation of Dilaasa was carried out, and it showed that the model had potential of scaling up. Rationale of the study: scaling up an effective intervention like Dilaasa widens the reach and ensures sustainability of service provided to survivors. However, there is an evidence gap for ensuring scale-up model like Dilaasa. Evidence-based interventions remains restricted to smaller settings, especially in LMIC settings. Additionally, maintaining fidelity of intervention is critical when it comes to scaling up. A need for study to understand facilitators and barriers for scaling up was felt essential. The study focuses on upscaling of public health intervention for VAW within the low-resource government health system in India. In this study, the lessons learned will help us understand factors that facilitate and influence a successful scale-up. We'll now discuss the objectives of the study. The first objective was to assess the extent to which various components of Dilaasa model have been replicated in the 11 Dilaasa centers. The second objective was to document the problems encountered in establishing a health sector response to women facing violence. And the third objective was to identify strategies that played a critical role in scaling up Dilaasa centers. To ensure triangulation, various data collection activities were carried out. It included survey, in-depth interview, focus group discussion. The respondents included counselors, auxiliary nurse midwife, and nodal officer. It also included survivors, and some key informant interviews were also carried out. Reviews of document included budgetary allocation by government orders, approvals, global approaches to reviewing implementation of health system response to VAW. I would now like Dinah to continue with the presentation.
Hi everyone, hope I'm audible. So my presentation will basically focus on strategies and facilitators leading to upscaling of Dilaasa model. So initially, before we start with this, there were various models models or strategies of scaling up which we reviewed, and the models like ExpandNet model, the WHO model, there were best practice consortium. So all these models, we found that these models were not suitable according to the current context in which Dilaasa was upscaled. And the one model that stood out for us was the ExpandNet model. The ExpandNet model, basically, the advantage of this model for our study was because it was a system-oriented framework and it had a systematic approach to increase the coverage of through a program development approach. Now, basically, looking at the ExpandNet model, the model consists of basically two aspects. The first one is the elements to scale up, which you can see is in the oval shape figure, while the bottom part are the strategic choice areas to scale up. So in the first part of the model, the elements of scale up includes the innovation resource. The innovation is the intervention that has to be scaled up. The resource team is the institution or the organization that has developed the innovation. Then there is the user organization, the organization where this model is expected to be implemented. And there is an environment which influences this upscaling. So all these form important elements of a scale up. Once these elements are in place, there is a specific strategy for scale up. The strategies include what kind of scale up is planned in this particular planned by the organization, which basically focuses on aspects like the dissemination of evidences for which is in favor of the innovation, advocacy by the resource team on the effectiveness or the efficiency of the model, specific process which the organization can use to implement these models, the aspect of cost and resources, which would include the financial aspect as well as the human resources, and also a mechanism for monitoring and evaluation. So this is what the ExpandNet framework basically talks about. So there are these two major prerequisites that come in with the ExpandNet model. Now, applying this to our Dilaasa model, the environment that you see, the innovation here is the Dilaasa model, which is a health system response model to violence against women, and it follows a feminist perspective. This model was piloted in 2000 along by Sehat and the Bombay Municipal Corporation, and it was found that this pilot model was successful. So this was the first innovation which happened. Once the resource team in this here is the central ministry, that is the National Health Mission of India, which is a national policy in India under the health ministry. The National Health Mission provided budgetary support and human resource allocation for this project. The NGO, that is Sehat, provided technical support to run the program. The user organization here was the Municipal Corporation of Greater Mumbai, which is the governing body of all the peripheral hospitals. So the Dilaasa program was expected to be implemented in the government hospitals of Bombay, which is run by the Bombay Municipal Corporation. The environment here plays a very critical role in ensuring the upscaling of this model. So it is at that point of time that the Ministry of Women and Child Development developed a one-stop crisis center model, which is also called as Sakhi Center in India. This model the first model was piloted in 2011, and after a year of its piloting, they found that this model was effective and they were ready for scale up. In 2012, in India, there was a rape case called the Nirbhaya rape case, which happened in Delhi in 2012. This rape case triggered outrage across civil society organizations and across the country on insensitivity by the health systems in dealing with survivors of rape. So this led to the ministry taking up action, the health ministry taking up action, which resulted in them implementing the sexual violence protocol, which had inputs from SEHAT as well. In 2013, the Ministry of Health also came up with a national urban health mission, which was a subset of the national rural health mission. The both the missions, the rural and the urban mission, is together called the National Health Mission. So under the urban mission, they had a program. They had a factor of including violence as a determinant of health. So under this factor, under this determinant, the Ministry of Health and Family Welfare, the SEHAT advocated with Ministry of Health and Family Welfare, and through this, the National Health Mission in Maharashtra implemented Dilaasa as part of their urban mission, and that's how Dilaasa department got scaled up in Maharashtra. So and through this national mission, it was implemented in 11 peripheral hospitals in Maharashtra. So you can see that the environment played a very important role in the upscaling. Along with the environment, there is also a lot of advocacy and dissemination that took place from SEHAT. The evidences which were provided was also a very important factor in upscaling. So the types of scale up that happened during this period. So as I've mentioned, since 2000, the first model was piloted in 2000. Since 2000, there were multiple other types of scaling. So according to the ExpandNet model, there is a horizontal scale up and there is a vertical scale up which happens. So the horizontal scale up is when it is replicated in different geographic areas, while the vertical scale up is when government adopts and institutionalizes the innovation in the national program. So the first horizontal scale up after the successful piloting of Dilaasa model happened in Bombay, again in another Bombay Municipal Corporation hospital, which was in 2011. And during this period, there were such replications which happening in multiple states in India as well since 2009. So these replications in multiple states happened based on their local context. They adapted the model to their local context and implemented it. So many states like Kerala, Karnataka, Gujarat, Goa implemented the Dilaasa model in India. And later in 2016, the government of India, under its National Health Mission program, took up a vertical scale up and was implemented in 11 peripheral hospitals in 2016. So these were the different types of scale up that happened in the Dilaasa model. Moving on to the strategies that helped in institutionalizing the model, mainly dissemination and advocacy was a key factor. Commitment and ownership by SEHAT, disseminating the evidences to the respective stakeholders, convincing the stakeholders. Also, SEHAT carried an external evaluation to understand the feasibility of the model and to see whether scaling up was possible. So all these evidences were presented, and therefore the evidence-based model was found to be effective. There was a lot of association and a lot of the SEHAT advocated it with the National Health Mission, and a lot of hospital implementers were also administrators were also part of this advocacy. So that was a major factor which enabled the upscaling. Under the organizational process, there was a massive training carried out by SEHAT to build capacities of healthcare providers. which included providers from the administrators to the implementers to the senior to mid-level personnels in the hospital, to even the personnels who are at the housekeeping level. Everybody was trained to ensure that the healthcare providers across the hospitals understood the concept of violence and were able to use that in their routine practice. There was a specific standard operating procedure which was in place while establishment of the hospital. So this included care, women-centered, the aspects of women-centered care, identification. How would providers identify each cases of violence through their clinical inquiry, and how a first-line support can be provided in the OPD. Apart from that, there were infrastructure which was available. There was a dedicated OPD which was given to Dilaasa. The dedicated OPD had its own OPD number, and it was located within the premises of the OPD, which ensured that it was easy access to the survivors and also provided privacy and confidentiality. There was an establishment of an internal and external referral mechanisms. The internal referral mechanisms would be references within the medical college, within the hospital, wherein every medical need of the survivor is taken care by the hospital. While external referrals would include a referral to police, to child welfare committee, to a protection officer, based on the context of the survivors. Cost and resource mobilization is another important factor which helped in upscaling, wherein the National Health Mission had its own dedicated budget line for Dilaasa. Along with the budget line also included budget for the human resource salaries as well as the supplies for the survivors. So this was a very important factor to ensure scalability and sustainability. Monitoring and evaluation, there were various monitoring and evaluation mechanisms. There were quantitative mechanisms, there are qualitative mechanisms. Some of these mechanisms include a specific monitoring committee meeting, which happens within the hospital every quarterly to understand the internal functions of the Dilaasa department. There are the management information system, which the Dilaasa department maintains, wherein we get idea about the survivors who come to Dilaasa centers and the kind of interventions that was given to them. There are monthly case presentations which happen with the counselors and the Dilaasa team to ensure, which is a learning opportunity for the Dilaasa team, wherein all the team members come together in every monthly to discuss one particular cases which is facilitated by Sehat. And this acts as a learning opportunity and also an experiential sharing for the counselors. So these were basically all the factors that helped in upscaling Dilaasa department. So finally, the major facilitators that led to upscaling Dilaasa, to just sum up these things, it would be integration, which was an important element in Dilaasa model. So when it comes to integration, the Dilaasa department, Dilaasa is a department within the hospital. So since it's a hospital-based model, it acts as a routine service within the hospital. So say a patient goes to a doctor in the OPD. The doctor may want the patient to undergo, may want the patient to go to, say, a particular OPD for referral, or would refer the patient to a lab or X-ray. So in the public hospitals in India, each of these departments have a number. So the doctor may ask the patient to go to OPD number 10 for lab, may ask the patient to go to OPD number 15 for X-ray, and then go to OPD number 20, which is the pharmacy, to collect medication. So that is the line of referral that happens in India. So when the doctor identifies a case of violence in the OPD, the doctor would ask the patient to go to all the other referral department and will also tell the patient to go to, say, OPD number 25, which is the Dilaasa OPD. And therefore, the patient will get all the medical services within the hospital. Along with that, the patient will also get reference to Dilaasa and will be counseled in Dilaasa. So this integration in the hospital is a key element in Dilaasa model. As we discussed the policy environment, the positive change in policy environment was a major factor in upscaling Dilaasa model. The presence of a budgetary allocation, having a financial allocation is key to any to sustainability of any model. So a particular budget line item for Dilaasa, which included provision for an infrastructure in the first year, and also for the routine services in the department, is also a key factor. Also, provision for human resources was another key factor. Moving on to feasibility, as I mentioned, the feasibility of this model is because of its location within the hospital. Since the department is located within the OPD premises, it is easy for access to survivors. They can reach out to the hospital on the pretext of ill health and get their services they can come to the hospital for follow-up and also get their services. So therefore, the easy access is a very important factor which led to the upscale of Dilaasa. And also, there is women reaching out to the hospital does not lead to stigma, as will not demarcate her as a person going for services for violence. So this is another feasibility of the Dilaasa model. And because it is a line item within the National Health Program, it ensures sustainability of this Dilaasa model. Also, the availability of evidences, as I already mentioned, the evaluation of Dilaasa model, the data through which monitoring and evaluation happens, all these play a very important role, and all these were facilitators for upscaling the Dilaasa model. So that's all from my end. I hope that this is clear. Moving on, Sanjida will take.
Thanks, Diana. Yeah, so I will be talking about opportunities in strengthening health systems response to VAW based on the findings of this study. So I will be talking about precisely about the factors that played an important role in health systems response once these 11 Dilaasa centers were upscaled in the 11 peripheral hospitals. And these factors are laid down as per the health systems building block on which the Dilaasa model is based. So coming to the first building block, leadership, the study found that the leadership played an important role in generating the ownership and sustainability of the response. We found that the champions, the core group of healthcare providers who were trained on the issue of violence against women and also trained their colleagues within the health system, played an important role in the extent of the integration of Dilaasa within the hospital, the institutionalization of Dilaasa, or I would say that they provide visibility and legitimacy to the issue within the health system. How much these core group of trainers were active, that determined the integration. So how they determined the integration? So first was the provision of strategic location. So health administrators who were active were able to provide the place or the space to Dilaasa's department within the OPD premises. And also, if because of the infrastructural issue, the place was not there, they were able to create mechanism to ensure privacy and the confidentiality. Then they also created an enabling environment for Dilaasa team members to work within the health system. So these Dilaasa team members, they go on ward rounds, and they speak to the women who get admitted in the hospital with the accidental consumption of poison, or who come with the burns or the other issues, and identify women facing violence. So these active health administrators ensured that the Dilaasa team members, they, just like other healthcare providers within the health system, they can get entry into the inpatient department and can interact with the patients. So they created systems where Dilaasa team members can play an important role in the provision of the care. Then establishing facility-based systems for providing sensitive care to survivors of violence. Then monitoring of the response also, like organizing monitoring committee meetings, organizing platforms where the Dilaasa team members can share their concerns as far as the medical treatment or the provision of care to the cases of survivors of violence is concerned. They also provided guidance to the healthcare providers on the legal mandate as far as response to VAW is concerned, like, for example, the rape examination or mandatory reporting in the cases of child sexual abuse. But we also found that there were some barriers to the active leadership, which were frequent transfer of the healthcare providers and also the workload of the healthcare providers, which prevented them from, actively taking part in the system's response to VAW. So here the graph shows that we also, as a part of the study, analyzed the MIS of these 11 centers, and we found that in 2018-19 there were around 3,300 cases who were provided services in these 11 centers, and about 74% were of domestic violence and 26% were of sexual violence. So this graph shows, so sexual violence cases, they mostly come with the police, and domestic violence cases mostly come with the health system. So through this graph, I'm trying to emphasize that the most of the cases that these Dilaasa centers are receiving are from the health system, and the active leadership has an important role to play as far as the identification and the referral to the Dilaasa department is concerned. Then the next is human resource development. We know that the health system's response is based on sensitive and trained healthcare providers. So we found that if there is detailed and well-defined roles and the responsibilities of the staff within the health system as far as VAW is concerned, then it results in effective response. So if you have one person within the health system who is the point of contact for the health system's response to VAW is concerned, then that works out. So here in this model, that person is called as nodal officer, which is precisely a healthcare provider with the additional responsibility of looking at the functioning of the Dilaasa department as well as the response of the healthcare providers to the survivors of the violence. Then we found that ongoing incremental training is one of an important element, considering that there is a high turnover of the healthcare providers, and also a platform where Dilaasa team members can share their concerns, can share difficult or the challenging cases, then that helps in providing the inputs to them. And then integration into routine orientation of new HCP. We found that many hospitals out of 11 were able to integrate orientation about Dilaasa within their general orientation of the hospital. Whenever the new healthcare providers come in a hospital, they undergo a 1-day orientation about the procedures and everything within the hospital. So Dilaasa has also been there is a session on Dilaasa as well in that, but still for few hospitals, integration of training on VAW as part of the overall training is a challenge. And then the next thing that we found, that training of the content be tailor-made for each cadre. So if the trainings are actually, they take place in a mixed group where we have doctors, nurses, social workers, pharmacists, even class 4 workers, having joint training, but at the same time there are certain specific content which can be focused on each cadre. Like for example, the nurses which spend more time with the patients who are admitted in the department and what kind of first line support they can provide, then that's useful. Then the other thing we found that since these Dilaasa departments have two counselors, two auxiliary nurse midwife and one data entry operator, we found that the allocation of dedicated staff in each Dilaasa center can be based on the size and the patient load in each hospital. So we found that it's not necessary to have five Dilaasa team members everywhere, but based on the footfall or based on the number of the beds, then we can have Dilaasa staff in the hospital. Because out of 11 Dilaasa centers, we found that in few hospitals the emergency department was not there. Even in few hospitals the gynecology department was not there. So there is no fixed criteria about allocation of the staff within the each Dilaasa team member. Then coming to the infrastructure, equipment, and commodities. So we know that this is the hardware of the health system, and the performance depends on it. And we found that the extent of integration determine the facility readiness. How much Dilaasa is perceived as a part of the health system actually determine the availability of these commodities. We also found that the availability of medical supplies and commodities was not a problem here in the Dilaasa departments, because it's integrated within the health system. This finding is in contrast to the assessment of the one-stop crisis centers, which are standalone, and there is evidence that most of the one-stop crisis centers, they lack medical supplies and medical staff as well. So this is an important learning that wherever the OSCs are there within the hospital or in the proximity of the hospital, integration within the hospital is essential. Then we also found that even if the infrastructure resources are available, if the leadership is not active or ineffective, it results in non-utilization of available resources. For example, there might be abortion pills which are available, but if there is no active leadership, there is no willingness, there can be denial of the abortion as well, or there may be denial of the medical treatment and examination to the rape survivors. Then financing, we found that the dedicated allocation of the funds played an important role. There was a dedicated staff within the Dilaasa departments. Also, we found that the way the National Health Mission budget was conceptualized, that in the first year when the Dilaasa was upscaled, then they had a line item of training of staff, and under that some budget was allocated. But over the years, there was no element of the training. So ongoing capacity building was not conceptualized as one of the need of this Dilaasa initiative. So the way the budget was conceptualized, that it's only a one-time thing, just like a capital investment, and there was no need, there was no recognition that there is a need of ongoing training. Also, we found that there was lack of clarity among the providers to utilize the available funds. So we found that over the years, there was a decline in the operational budget, with operational cost that was allocated in the budget, precisely because of non-utilizations over the previous years. And when we interviewed some of the nodal officers who were the healthcare providers given the charge of the hospital's response to VAW, they lack clarity about that how these funds can be best utilized, and also there were some administrative problems in utilizing those funds. Also, we found that the there was poor pay for Dilaasa staff along with the contractual nature of the job, and the absence of security and benefits, so which resulted in a lot of attrition of the staff. So the way these Dilaasa staff members are recruited by the National Health Mission, they are on contractual basis. The pay is actually relatively low. Also, they are not given any benefits, which results in a lot of attrition between the staff, and which actually also impacts the quality of the care, because then a lot of training needs to happen for those staff members. Then coming to the service delivery, location of Dilaasa played an important role within the OPD premises. If it is there, then the data shows that the about 74% of about 88% of the referrals to Dilaasa are from the health system, which includes IPD, OPD, casualty, and hospitals, the sensitive hospital staff, including class 4 workers, pharmacists. And then also the presence of a SOP played an important role. So this SOP is a written document which is there in all the 11 hospitals, which states that how the system's response should be to VAW, what are the minimum requirements and all. And this SOP has been developed in a participatory manner with the healthcare providers. Because though the healthcare providers are the ones who are going to implement this protocol. Then this we, as I spoke earlier, that about 88% of the cases are referred from the trained healthcare providers. So they have integrated it into their clinical practice, where based on certain signs and symptoms like like anemia or repeated pregnancies, attempted suicide cases, or accidental consumption of poison cases, these providers refer women to the Dilaasa department located in the hospital. Then readiness of the health facility also determines the service delivery. Then in the service delivery, we found that the care provided by the Dilaasa team members is survivor centric, where we interviewed some of the women and found that the principles of the autonomy and feminist counseling are respected. Then needs of vulnerable groups. So these Dilaasa trainers are routinely trained, and also they are given the platforms where they can share their challenging cases. So they are trained on the issues of the specific needs of the vulnerable groups like LGBTQ and her, and they pave the way for the sensitive care to the marginalized groups. Then in the multi-sectoral coordination, we found that the Dilaasa department, they have coordination and rapport with the multiple sectors, including the shelter, legal aid, and police. And we found that the active leadership at the health facility played an important role in establishing the rapport with the formal agencies like police and all, as far as the cases of the sexual violence are concerned. Also, some of the monitoring committee meetings, they have stakeholders such as police as the members of the monitoring committee. So this helps in establishing the rapport, and also if there are any violations from any of the stakeholders, and also it builds the mechanism of the accountability, where these stakeholders can be a part of establishing comprehensive care to the survivors. Then developing networks with the smaller facilities. All these Dilaasa centers are resourced with a directory which has a list of the organizations and legal aid agencies which are in the vicinity of the hospital and can provide services to the survivors. But at the same time, one of the thing that came out from the study is that uh, there is a need to strengthen this multi-sectoral coordination, develop networks with the smaller facilities, both the NGOs agencies as well as the health facility, and a protocol can be in place to establishing these linkages. Yeah, and then establishing linkages with one-stop crisis center was also found to be one of the recommendation as part of the study. Then the other one was to strengthen the linkages with the smaller health facilities these are the peripheral hospitals, so like primary health facilities or the community health workers, and which can and the mechanism for the upward referral can be established where the community health workers and even the healthcare providers at the primary health center can play an important role in identification of women facing violence and then making an upward referral to the Dilaasa centers located in the secondary facilities in Mumbai. Then coming to the monitoring and evaluation, so we found that there are processes of documentation of cases by the Dilaasa team, but this was found to be the weakest part of the project implementation. We found that there are variations in how the cases are documented. There was missing data. There are different mechanisms how they report data, what are the indicators across the 11 Dilaasa centers. So we found that this is something that we need to improve on. Then active monitoring committee at the level of the hospitals. So some of the hospitals, the monitoring committee was active, while the others, the Sehat had to play as a technical support partner, had to play an important role to activate the monitoring committee members and implement the routine monitoring. And then role of the advisory committee for running these centers, there has been a notification from the NHM to set up an advisory committee. Advisory committee is in place, but there is nothing that has occurred after that. So it's important that the role of the advisory committee can be strengthened. Then also there is a need to strengthen the accountability mechanisms at the level of the National Health Mission and the Bombay Municipal Corporation. Then one of the recommendations that came out was that if the NGOs can be a part of the routine audits as far as the systems response to VAW is concerned, which will help in effective monitoring and evaluation. Then one more suggestion which came out from the key informant interview, that the response to VAW should be considered as one of the criteria for accreditation of the health facility. So these hospitals are accredited according to the certain national standards, whether the proper infrastructure is there or whether they are adhering to certain standards. So if response to VAW and the facility readiness in context of that can be a part of the accreditation process, then that will help in strengthen the response as well as sustain the health system's response. So these were the findings as per the building blocks, but just to summarize that, we found that the active leadership at the level of the health system really played a very significant role. Even the hospitals where the infrastructure, to say that the location within the OPD was not available because of lack of infrastructure, the leadership, active leadership made ensure that all the referrals from the healthcare providers is happening, even if the Dilaasa department is located at the 3rd floor and the OPD is at the 1st floor. So we have a few examples from the 11 centers where Dilaasa departments, actually 2 hospitals where the Dilaasa departments is not situated within the OPD premises, but actually at 3rd or the 4th floor. But if you look at the referrals from the healthcare providers, it's at par as the other hospitals, which is just because of the active leadership at the level of the health facility. So I will just stop here, and then I would request our both discussants to say their remarks, and then Professor Surinder can summarize the findings for us, and then we can open for the discussion.
Thank you, Sanjita. Would you like me to start or
Yes,
Mary?
yes. You can start, Elizabeth.
Thank you. And thank you to the CHAC colleges for the colleagues for the invitation to be part of this really important panel. And thanks to all the panelists for your wonderful presentations, and thank you to everybody that's joined us online. I've been asked to comment on around sustainability and is it a key factor while designing interventions for violence against women, especially in the context of future scale up. And to also talk about what are some of the strategies or practices to be followed while piloting health systems-based interventions on violence against women to address issues of feasibility and sustainability. So that's the framing of what my commentary is going to be about. And much of what I'm going to say really does resonate with what has already been shared. But just as we start, I think we just need to be reminded how crucial the health system is in playing a role in responding to violence against women. We know that women experiencing violence are more likely to visit health services than women not experiencing violence. That health systems and healthcare providers play a very powerful and very central role in the lives of women experiencing violence and serve as a critical entry point to essential and potentially life-saving services. A kind word and a warm, affirming and non-judgmental reception to disclosure of violence can be a transformative and healing experience for a woman reporting violence. So ensuring all women experiencing violence have access to healthcare is a critical goal of all health systems. And as we've heard earlier, that evidence on successful integration and scaling up of violence against women programs in health systems is scarce. What does exist is generally situated and remains in high-income countries with very few resources available for us researchers and practitioners working in lower middle-income countries to understand strategies or practices on how to sustain health system responses for violence against women at scale. And hence, this presentation and this work that's being done is so important. I just really want to remind us all that there is inequity in resourcing for evidence building in lower middle income countries, and it's well documented for all forms of research on violence against women. And we must, as a field, continue to advocate for more and better resources for research on violence against women and violence against children in low and middle income countries, led by researchers and practitioners from lower middle income countries. And again, this is why the Dilaasa work is so powerful. And as already noted, and why studies like the one being launched today is so important, and that why studies and initiatives exploring the success factors and challenges to sustaining violence against women programs feasibly at scale are so few, and those that do exist focus more on the practical barriers faced when attempting to scale up programs rather than sustainability. And there is much debate on what actual scale up does mean and what does it look like. For prevention programs, a group of 8 organisations working across the world called CUSP, the Community for Understanding Scale Up, is a really important initiative representing a unique perspective of evidence-based approaches to gendered social norms change and continue to inform our understanding as a field of scale. And CUSP challenges the standard definition of scale, which focuses on economies of scale and assumes that unlimited growth is good. Scale up at the moment is currently defined as deliberate efforts to increase the impact of innovations successfully tested in pilot or experimental projects so as to benefit more people and foster policy and program development on a lasting basis. And of course, that's a great thing. But CUSP also notes that this, and I quote, apparently quite straightforward definition has given way to the use of the term scale up as it's framed in the business world, not in the health sector, in the world of violence against women. And scale up is scaling is not just about reaching more customers, but doing so for less. That is achieving economies of scale or ensuring more bang for the buck. But as a field, what we're learning and what Dilaasa is teaching us is that very few programs work at scale. And if the programs that are taken to scale without fidelity to the original program, they may even be harmful to women. The more bang for the buck metaphor mentioned above is one such reason. With the pressure to scale up violence against women programs, core aspects of programs are often cut to meet shortened timelines and limited funding. Taking programs to scale, if not thought through properly, can result in high levels of investment for no bang for our buck. And as mentioned, even potential harm to women who we are wanting to support. I want to talk a little bit from a different perspective. John List, an eminent behavioral economist who uses field experiments to explore economic questions, including why many social programs, unlike Dilaasa, in experimental conditions, are found effective, fail when expanded to larger groups of people. John List says that while costs are a key cost for failure, they're not the only ones. List believes, and I think this is something that we need to think about as a field, is that we need to revolutionize the way that we do research. And I'm talking now to the question around what do we need to think about when we're piloting. He says we need to move from doing research to inform policy to doing policy-informed research. Now, let me repeat that. He says that we need to move from doing research to inform policy to doing policy-informed research. So what does he mean by this? We all know as researchers, we really do want our study findings to come out positive. And so we pilot our programs not with implementation in mind, but rather with the best possible outcomes in mind and the program's success in mind. This includes how we select participants, how we select and train and support facilitators of our programs, and many other aspects central to a program's success. For example, when we're selecting facilitators for healthcare workers for a study, we might not select them in the same way a government will be hiring a healthcare worker. And so inherently, the program is flawed from the beginning, as the people implementing the program in the study are going to be different from those who will be implementing the program in real life. Furthermore, the people responsible for piloting and testing a program for scale-up often are not from the context within which those programs are going to be implemented. So taking a feminist approach and learning from CUS, a more integrated, a more localized approach like Dilaasa that acknowledges the realities within which the programs are going to be implemented need to be front of mind when we're thinking about sustainability and scale when we are piloting our programs. For instance, the local reality for many women experiencing violence in low and middle income countries is, with very few exceptions, really poor, with very few services, and generally those services that are available, pretty poor quality. A recently published study in 3 countries in Uganda, Kenya and Colombia by Clarissa Bencomo, Emma Battistini and Terry McGovern found existing medical and psychological services to be wholly inadequate in these 3 countries, with facilities lacking the necessary infrastructure, including private spaces to examine women, victims having to pay for examinations, and rape kits and emergency contraception generally just not being available. So in addition to who is selected to deliver the services and how they are trained and supported, our pilot studies have to consider what exists and the limitations that will impact on the services and incorporate these into the scale-up plans and how much it's going to cost to address these gaps. Echoing these factors and the factors that Sangeeta has just presented, a systematic review of 11 studies of health sector responses to intimate partner violence in low and middle income countries done by Manuela Colombini, Colin Doherty and Susanna Mayhew identified very similar factors that Sangeeta affect, that the availability of factors for a delivery of quality services to survivors. These included the availability of clear guidelines, policies or protocols, management support, intersector coordination with clear, accessible on-site and off-site referral services. Of course, adequate and trained staff with really accepting, kind and sympathetic attitudes towards survivors of intimate partner violence, training for health workers that is initial plus ongoing, and a supportive and supervised environment in which to implement these new IPV protocols. And all of these factors have to be integrated into the health sector violence against women response efforts when taken to scale and in our pilots. So what does work? What are some of the models that have been found to work? Like the Dilaasa model, Partnerships between government and non-government sector have been proven to be very powerful models for leveraging the health system to deliver quality post-rape and domestic violence response services, where, for example, the healthcare and justice services are provided by government and capacity strengthening psychosocial support are delivered through non-government organisations. It doesn't always have to look like this, but this is just one type of model. And this approach is said to make services more efficient and more effective. But even so, such models face the same challenges already discussed, and the same facilitating factors are needed for quality and sustainable violence against women programs to expand their reach. And of course, and really important, and something that the Dilaasa model also highlights, that sustainable and flexible funding for the NGO sector and allocation of funds from governments for violence against women response and prevention services in low and middle-income countries remain a critical gap. And this funding hinders uninterrupted delivery of good services and retention of excellent staff. And the Dilaasa model does highlight how important the support from the government for this model has been, in particularly around funding. So thus, funding gaps, challenges and facilitating factors providing quality, health and psychosocial services to violence against women survivors all must be addressed in our pilots. And we must consider the way in which existing systems can integrate them into real life settings when we study and evaluate programs. Scale up and adaptation must be front of mind when we pilot our programs, rather than just an afterthought or something that we think about when we're going into implementation and scale up. Finally, just one more final point from Professor List. We should never consider taking something to scale without good science behind it. I know we all know that, but it does happen. Small sample sizes, one replication of study effectiveness, or no study at all. This just is not a good idea, leaving success at scale to chance. So as Professor List says, let's revolutionize. Let's start doing policy-informed research and use this research to build better, more contextually relevant, sustainable programs that can be expanded to improve the lives of all women. And we have the evidence that we can do it. Thank you so much. Now I'm going to hand over to you, Mary, to continue the conversation. And I think Angelica has shared the references that I referred to in my reflections. Thank you.
Thank you very much, Liz. And I'm really glad that you went first, because that was a fantastic overview of the challenges of sustainability and scale up of integrating violence against women, IPV prevention and response into health services, which is something that has been tried in high-income countries for many years with very mixed success, and is beginning to be addressed more in low and middle-income countries. And I think that Sehat's model of the Dilaasa model is an excellent contribution to global evidence and learning. And so I'd like to start by thanking Sehat for inviting me to be on this really important panel, and for the opportunity to hear about the fantastic work that you've been doing over the years. I've had the opportunity to visit the Dilaasa centers in Mumbai and a few years ago, and was incredibly impressed by how well organized they were, and meeting with both staff from the Dilaasa Center as well as nurses and other health staff from throughout the hospital. And I think that, and what I'd like to focus on are some of the areas where I think that the Dilaasa model really is making an exceptional contribution that we can learn from globally. I've visited one-stop centers in many parts of the world. Some of, as you know, many of them are in police stations, but there are also many that are carried out either in coordination with the health ministries or within hospitals or health centers. And this is both in high income as well as low income countries. And I think that the Sehat the Dilaasa model really builds on learning over the years from what works and what doesn't work. And that's one of the reasons it's been so successful. One of the problems with counseling centers, even within health services, is that they tend to be funded with external funding, often by outside donors. They often have their own staff who are not part of the Ministry of Health. And if any training is given to the rest of the health services as health staff, it's usually one-off, and it's not something where there's ongoing coordination. So in the case of Dilaasa, what I think is really important, first of all, is that it's integrated into the services. And my colleagues from SEHAT mentioned this over and over as one of the real facilitators of success. As I said, in other centers, for example, a health counseling center that's been going on for years in Honduras, almost all of the referrals come from the courts, not from, even though they're located right in the health facilities. The health staff in primary care or in the hospitals knows that the center exists, but don't think of it, don't do any kind of routine inquiry or screening, and they don't and there are no referral mechanisms between the two, and that's a huge disadvantage, and also missing opportunities really to be able to address the needs of women who are coming into the health services for other reasons, but are also living with violence. So the fact that Dilaasa model is really using a systems approach, which is considered the best practices for this, as I said, integrated into the health services, and most importantly, with budgets from the Ministry of Health. That is very unusual. And I think it really speaks to the level of sort of advocacy, the issues of communication and dissemination, which Sangeeta mentioned as being crucial for creating this enabling environment and ownership of the Ministry of Health of the program itself. The fact that it really facilitates internal referrals, and that the majority of women coming to Dilaasa centers are actually being referred from staff within the hospital really speaks to this level of coordination. Also, I really appreciate the feminist approach that's integrated into the model, and that high quality, compassionate responses that are survivor-centered are emphasized for everybody who visits the center. The existence of the nodal officer, I think, is also really important, and this is something that that I've seen and has been documented. For example, in many cases in high-income countries, in the United States, for example, the problem has been that they will do sort of a one-off training of all of the workers, or they might create a center with specific counseling, but then there's nobody to kind of monitor the integration to make sure that that problems are being resolved along the way, that coordination is taking place. And having the nodal officer is really key to this, to make sure that it's moving smoothly and that you have continuous follow-up. Another big problem that all projects that I've seen have had is turnover of staff. You train one group of staff and then they leave, and the whole project just falls apart. So the nodal officer is important for that, but also this ongoing training that my SEHAT colleagues talked about. And the fact that the role of the Dilaasa Center is included in routine onboarding of all health officers. And then finally, I want to point out the continuous monitoring and evaluation and how that has been just an integral part. It's not just an extra piece that comes in once in a while, or from external people, but that the staff and SEHAT themselves are continuously monitoring and evaluating the program. And also as they were upscaling to different hospitals, also understanding that it's not a completely, it's not a rigid model. It's one that should be adapted to the circumstances of each center. And then finally, the collaboration with the medical college and having now a whole cadre of trainers and within the medical college, within the hospitals, who could do the ongoing training, and also to help ensure that as doctors are being trained in their primary training, they're already learning about how to provide compassionate care to survivors of violence. The final piece here, which I think is evident from all of these presentations, what's really unique is the partnership between SEHAT and the National Health Ministry. And as Liz pointed out, these kinds of partnerships are crucial and also in the case of SEHAT, really unique, that this has been an ongoing learning journey between the two of them, and that they have this they've developed this very strong trust and collaboration between nonprofit and health ministry is also unusual and really commendable. I'll just end by saying that there are a few areas that were mentioned by my colleagues that I think are areas for growth in the future. One of them is to see how this model can be extended and expanded through primary care, and particularly how it can be leveraged to address prevention, so that it's not just response to survivors of violence, but also finding ways to talk about violence and do primary prevention, particularly in the primary health services. There might be some role for community health workers. I know this is something that's been discussed a lot in India and elsewhere, but there are certainly opportunities to understand more how these kind of cadre can be leveraged. I also think that it would be useful to in future studies to be looking at the impact on survivors themselves. And I definitely don't think that randomized controlled trials or experimental designs are necessarily the most appropriate kind of research in every setting, but they do contribute to the evidence as to whether not only are the programs working smoothly and women appreciate them, but also really trying to show how the program is having an impact overall on the mental health, on the issues such as self-efficacy that we've measured in other places that are very often improved, just as a woman's sense that not just of well-being in general, but feeling that she has more agency and ability to resolve problems in her life, to take important decisions. All of these could be measured and could contribute to the evidence base. I should mention also that as the director of the research consortium of the What Works to Prevent Violence Against Women program, which is a large program that has just been launched, the second phase of which has been launched by the UK government. There are two pieces of it. One piece is giving grants for innovation in violence prevention, and the consortium that I lead as the Global Women's Institute is doing the research and evaluation to look at effectiveness and cost effectiveness of the different programs. SEHAT, we're very proud that SEHAT is a member of our consortium, and we look forward to opportunities to partner with SEHAT in the future to continue to look into these important questions that we've been discussing around scalability and sustainability. And I'll just close by, again, congratulating SEHAT for this amazing work and to thank you for inviting me to be on this panel.
Thank you, Liz, and thank you, Mary. Professor Surinder, I would like to request you to now share your thoughts and also facilitate the discussion.
Thank you, Sanjita. Sanjita, am I audible to you?
Yes, Professor Surinder.
Yeah, I had a little difficulty in joining on my laptop, so I'm doing it from my iPhone. So trying to make the best of it. Thank you very much. At the outset, many thanks to the SEHAT team for inviting me to be part of this dissemination of very important research report on scaling up of health systems response to violence against women. As we heard, the piloting of the Dilaasa Crisis Center, it took place in 2000 after almost a decade of work of trying in India to help prioritize public health, to prioritize violence against women as a public health issue. And the Dilaasa model, I must say, has gone a long way in not only establishing that fact, but also integrating it into the health system. The second part, where they upscaled the Dilaasa model to 11 peripheral health facilities, is a very, very important piece of work which is being shared today, and which we heard from the Dilaasa team, which shared with us in detail about the Dilaasa model, the study methodology, the strategies and the facilitators which led to upscaling of Dilaasa, where they have used the building blocks of the WHO model, as well as the opportunities in strengthening health systems response to violence against women, which I must say Sanjita explained in great detail and clarity when she presented. We then heard Elizabeth and Mary, the two discussants for today's research report, highlight some of the things which have been takeaways for us, as well as areas which can be addressed further in future studies. I would like to reiterate a few points made by both the discussants, and which I also felt were very, very critical in our takeaway from the Dilaasa upscaling, as well as for future work. One of the things that we heard both the discussants speak about is that we need to continue to advocate for setting up services related to violence against women, particularly in the health system, in low and middle income countries, because these are comparatively recent initiatives. The Dilaasa model, of course, is one of a kind and has seen great success, but it is important for us to see that further strengthening of health systems continues across the country. And one of the things that was pointed out, and which I also think is very important, and the report also highlights, the Dilaasa report also highlights, is the need for models such as the Dilaasa model to network and link with other models which exist in the country, such as the One-Stop Center, as well as other initiatives of civil society groups, as well as other organizations, to help streamline services, as well as provide seamless services for women, and to reach out to those who are unable to reach the health facility probably at the first point. A very important aspect which we heard is the integration into the health system. And we have seen this actually in places like Mumbai and in 2000 through Dilaasa, that when you integrate the services related to violence against women into the health system, it leads definitely to sustainability, it leads gradually to scalability, and also leads to deepening of services and ownership of the services by the health providers across the block, in terms of right from the nurses to health providers in specialist areas, as well as all others who the women interface with. Sanjita mentioned accreditation as one of the areas which could be highlighted within hospitals based on the services provided by the hospitals. in the area of violence against women. And I thought that was an excellent point. More and more one finds that there is accreditation which is being encouraged in secondary and tertiary healthcare facilities. And if this is one of the components which is brought in towards the accreditation, I think it will help in both integrating and strengthening of health systems with regard to services related to women in violence. Elizabeth pointed out that whilst we need to think in terms of scalability and sustainability, etc., one of the important learnings that she has come across, as well as what we found the Dilaasa model throws up, is that we need to address the practical issues which arise in our work whilst providing services for violence against women in health facilities. And I think a lot of learnings that emerge help us to make the services better over a period of time and gradually take the programs to scale, which, if the practical matters are not addressed, can also can be harmful at times. So we need to keep in mind that pragmatic responses with regard to localized responses and keeping in mind the diversity of requirements and needs of women must be one of the issues that needs to be kept in mind. One other point which Elizabeth pointed out, which I found very interesting, is the policy-informed research. I think all of us who are here today, as we listen to the dissemination of the research report, would agree that this is one approach which would definitely help to take the issue of violence against women further if we changed the paradigm from research for policy to policy-informed research. And she has explained it in great length and also provided the requisite references for it. The localized approach and the feminist approach, which the Dilaasa model has undertaken, both our discussants, Mary and Elizabeth, were very appreciative. And it is true that these two approaches have actually helped to take the Dilaasa model, make the pilot project a success, and also the upscaling has been far more successful, particularly both in integrating the services as well as in helping better referrals for women to other health systems too. I think we all recognize that it has taken us a long time to create visibility for violence against women as a public health issue, even though both the health system as well as all of us recognize that most women enter the health system in order to receive a response to what they would like to share with the health providers and to get help. But this does not always happen. So partnership with health system for organizations which are working with women is definitely the way forward. And the Dilaasa model has shown that only when you partner with the local health systems is this particular model successful and would be able to meet the objectives that it sets out for itself. The collaboration with regard to funding, with regard to training, with regard to capacity building, with regard to further integration into the current health system through the health ministry at the central level, such as the National Health Mission, which was done by Dilaasa, as well as active partnership and work with the local systems, such as the Bombay Municipal Corporation, I think has been the cornerstone of the success of both the pilot and the upscaling of the Dilaasa model in addressing violence against women. And these are lessons which we need to take further in order to see that this model can be scaled, can be replicated. Of course, in the health system, which is which has a particular way of addressing as well as alienating the clients, the people who come to report health problems. If, with regard to violence against women, the feminist approach had not been used, we are not really sure what the response to the Dilaasa model would have been. So again, the fulcrum of the Dilaasa model's success is also the feminist approach, which, whilst working in partnership with the health system, retained its unique features such as a compassionate approach, having a women-specific OPD, where the methods of functioning were specific to the requirements of the women, as well as the kind of supports that were required. I remember in the beginning years how Dilaasa used to help women who came into the OPD to be admitted into the IPD of the hospital in order to receive the shelter that was required at specific periods of time for women in order for them to receive the services and to be helped. Continuous partnership as Dilaasa has maintained with both the local health system as well as the government has also meant that the staff that they have been able to both train and continue with to provide services, the iteration has been far, far less, which has helped to definitely better services, and for women also, building rapport and continuing to work with them has been easier. Whilst working within the health system, while it has been important for Dilaasa to work within the frame of the hospital, they have also maintained a flexibility and adapted based on the requirements of the women who approach them. And as the discussants have pointed out, this has also led to the success of women continuing to come and use as well as pass by word of mouth about the services that are available, and for the model to be used by women who require it. I would like to end by saying that going forward, two things which this particular model could definitely work towards is one, integration of the primary healthcare services, that is reaching out also to primary healthcare centers, because earlier studies, particularly in the first phase of violence against women studies, has shown that a large number of women do approach the local centers, the ones which are closest to them, in order to receive services at a point before they become the sequelae appear. And as Mary also pointed out, if we are to shift from the survivor to prevention model, then it is important for us to move from the secondary and tertiary healthcare, if not move, to engage much more with primary healthcare centers too. And studies, in order to show the impact of the interventions such as Dilaasa, it's very, very important that we have in place research studies on an ongoing basis which are able to kind of support our learnings with regard to, as she rightly said, self-efficacy, how women not only address the issues for which they come, but the kind of change that comes about in terms of agency, in terms of autonomy, and in terms of being probably productive members of society. It's not always easy to do research in the kind of interventions that Dilaasa has initiated, but I think over a period of time, as this model gets better established, and as the health facilities develop a better partnership, it would, going forward, be easier for us to initiate longitudinal studies which collect information from the time that they are first approached by a woman to the changes and the shifts that come about over a period of time. I would like to open up now for questions because I think we have about 15-20 minutes, and I can see that there are a few people who want to ask questions. Sanjita, do you want to take from the chat, or would you like the respondents to ask questions directly?
Maybe we can start from the chat, Dr. Surinder.
Yeah.
Yeah, so Mary, do you want to respond to Mukul's question about carrying out the economic evaluations, the intervention?
Yes, just to say that I totally agree that part of the evidence that we need to be producing to increase scale up is showing that this work can be done at a feasible cost. And I think the point that you make is very important, is what is the outcome that we're measuring the cost for? Is it the cost of the services themselves? I think we need to look at, and this is why I think we also need more experimental data, is that we need to be able to show what the actual effectiveness is for survivors and what the cost is per, for not just for the women reached, but also for the benefits that they receive. And I think that's a very tricky one. So we need to really think about what are appropriate and feasible outcomes that we should be measuring. And often we only measure by whether violence itself has been averted or stopped. And that's not something that often or usually even depends on the survivor herself. And so I think one of the problems we've had in high-income countries in these kinds of studies is that reduction or elimination of violence becomes the only outcome. And I think issues such as increasing well-being, increasing self-efficacy, mental health are also really important outcomes. So thank you for that question.
Yeah.
Thank you, Mary. Yeah. Sangeeta, would you like to respond to Sunita's question about feminist organizations working with non-feminist health facilities?
Yeah, thank you for that question, Sunita. It's actually a tricky one, and I'll try and this is the same question about the NHM and Sehat integration piece around the village cluster. Have I got that right, Sangeeta?
No, that's also, and the other one she asked that the feminist organizations working with the non-feminist health systems, and what are the special steps taken by Sehat to engender the system?
Okay, so I will go with the part 2 first. As you rightly pointed out that many health systems and hospitals are in a sense more hostile spaces to integrate any kind of interventions, feminist interventions set aside. But I think we've called them as standards of care and kind of put down what are the non-negotiables. And I think those standards and the fact that they are not one-time standards implementation, but that the Dilaasa centers and its teams meet on a monthly basis, where there's a discussion on challenging situations in counseling, on well-handled situations in counseling. So a mechanism is created, I would say, to really monitor the quality and the perspective of the teams which are working on the ground. And over time, that has resulted into development of a feminist lens to deal with the issue at hand. But yeah, conceptualizing it as a quality of care has sometimes helped us to work with a formal health system. So I think it all also depends on how do you conceptualize it, because on ground teams are really far more open to implementing a feminist lens to interventions. So you will see a massive difference where joint meetings are only held at the behest of women and girls, and the principle being negotiation for non-violence and not really either adjustment or, save the family. And that's a marked difference that I would say we see through these interventions. Yeah. I hope I have answered your question, Sunita. Thanks, Sangeeta.
Sangeeta, you could also speak about, the efforts that are being made by your team with regard to the curriculum, so that these are more long-term changes that you'll envisage whilst you work with people on the ground and current teams.
Yeah. Thank you for that. Actually, both Claudia and Avni are here, and it is the 2002 or 2005 the learning document from the WHO that spoke about, while in-service training of health workers is crucial to develop a gender lens and to respond to gender-based violence. It's also important to catch medical providers at a young age, which is the pre-service medical training, which is the MBBS curriculum. And Sehat has actually engaged in the space of pre-service medical education in Maharashtra for about 8 years, where an entire effort was made with the Maharashtra University of Health Sciences to look for spaces within the MBBS curriculum to integrate a intersectional lens. And within that, we've looked at spaces where gender-based violence and addressing it through the lens of either clinics as well as the entire lives approach by the WHO must be integrated. And there is an additional lecture now in the MBBS curriculum that has been integrated for all of Maharashtra at least. And we are underway in other states to see how that plays out. Yeah, thanks, Surinder. I missed that.
Yeah, Professor Lakshmi, you want to ask some question?
Yeah, may I?
Yes, please.
Yeah, good evening, and thanks very much for this presentation. It's always very heartwarming to hear about Dilaasa's work and also the presentations that come from very rigorous attention that you pay to, carrying out research to be able to share with all the community of people who are concerned about the subject matter, and also try and see how it can provide opportunities for many other institutions and also friends from other countries to be able to replicate. I wanted to respond to this point about carrying out research from the policy towards looking at implementation, and quickly share my own reflections on what seems to be really happening on the ground. So we do see, while we have done study in 2 states, we do see that infrastructure wise many hospitals are being augmented because of, let's say, Niti Ayog's, which is the planning department of the government of India for friends from other countries, which monitor regularly on a health index how hospitals are having their infrastructure being augmented, and also their staff and functionaries positions being filled. So that's something that seems to be improving. But what we often find is all the necessary elements that need to be in place to, both in terms of caregiving and also medical evidence gathering is really short in most of the hospitals. We have looked at primary health centers, we looked at the community level health centers, and also district hospitals. So we did see across the board all these vary. And one of the biggest issues is extreme poor knowledge about change in legislations pertaining to all kinds of violence, whether it's POCSO, domestic violence, or the rape laws. While doctors seem to be having some understanding, you do find that nurses, auxiliary nurse midwives, and ASHA workers have very poor knowledge about change in laws. So essentially, then what happens is they tend to disbelieve the woman who comes to them, either with telltale marks of domestic violence or sexual violence. So they often are not believed. And police system basically dictates what the health system should do. And these are areas, I think, which are really very worrying and call for our attention as to, how do we make sure that the interventions that Dilaasa has tried can actually be scaled up and can work very well without really having an NGO like Dilaasa on a regular basis to see that there is a hand holding and also oversight and monitoring. How does one bring that uh, as part of the mainstream part of the health systems? Is a very big challenge, and I think we need to really look at that. The other bit that I also thought, like friends were talking about accreditation, I was also thinking, how do we actually, engage with the Niti Aayog so that the health index monitoring also has infrastructure and knowledge and practices pertaining to all forms of violence against women. Those indicators are also there, and Niti Aayog gets those regularly monitored. That way, it would be at a national level. There would be attempts to try and see, issues to do with capacity building and also infrastructure augmentation, and necessary budgets in place to get all these things going probably would happen. So my basic thing is, how do we move from this micro experience of a very fabulous way of being able to do things to go to a macro level? And just to say, our study was in Maharashtra beyond Mumbai, and we didn't see any great shift at all. In fact, the results are quite, discouraging. So I think we have much more work to do, and let's all put our heads and hands together to do this. Thank you very much. And allow me to just share our report. I've seen other friend also has shared several publications, so I'll just share for friends here to help us cross down. Thank you.
Thank you, Dr. Lakshmi. Renu, you have any question?
Yes, hello. So, first of all, I would like to congratulate on the research by Sehat. And secondly, I had a question. It was regarding how does Dilaasa intervene? It interferes with the legality of the war cases post identification of the survivor. I mean, what is the process like? Does it happen by the team present at the hospital? And how is that dealt with the healthcare workers? So that.
Sanjita, maybe you can answer.
Yeah. So at Dilaasa, the survivors seeking services from Dilaasa are mainly identified by the healthcare providers based on certain signs and symptoms. And then services are provided by the Dilaasa team members depending upon the needs of the women. Whether it's emotional support or shelter, home, or legal aid. If the women or the survivor requires legal aid, then these Dilaasa centers, they have a lawyer who visits these centers, and also the counselors are trained in providing the basic information to the survivors about the laws which are available, about her rights and her options which are there. And as far as the under 18 cases are concerned, especially the cases of sexual violence, there is, because of the law, the POCSO Act, protection of children from sexual offences, there is mandatory reporting by the healthcare providers. So, as a part of the Dilaasa initiative, the healthcare providers in these hospitals are sensitive and trained to seek consent from the minor girls about any before carrying out any examination and treatment. So a lot of cases that the hospitals get are of the consensual sexual relationship under 18. So because of the POCSO, it's the any sexual activity under 18 is criminalized. So these young girls are coming to the hospitals for medical legal examination. But because of the trained healthcare providers, these providers inform girls about the implications of undergoing these medical examination, and they are trained to document the informed refusal of the young girls for the medical legal examination and treatment. And at the same time, there is a way where they document the cases within the within the register, but if the girl refuses for informing to the, doesn't want to file any case because it's mainly the boyfriend, it's the consensual sexual relationship, then that is also documented by the trained healthcare providers. I hope that this answers your question.
Yes, thank you.
So any more questions from participants or any comments?
There
or
are two hands raised. I think there's Claudia and then Dr. Malik.
Yes, Claudia, please go ahead.
Thank you. I think Seema was beginning, but if it's okay, I'll go because I do have to go at the 2 on the dot. I think firstly, thank you and congratulations. I mean, I also visited Dilaasa way back when, I don't know, when it was just in one hospital. So it's really exciting to see how you have been able to get the uptake. And I think, I echo the comments that were made by Dr. Surinder and by Liz and Mary in the discussion and that have been raised. I want to flag just a couple of things that I think really echo with what we've seen, both in our work with CHET in India, but also in other countries, about the importance of the engagement of government. And I think, as somebody pointed out, not just government at a national level, but really working at the local level and getting that buy-in. And also the importance of having champions and, how you identify those champions. And I had a question in terms of I think it's also, as has been said, a great example of the partnership between government and NGO. And I wanted to ask a little bit about, what do you think are the elements that have made that partnership work so well? And, would it have been possible 10 years ago? Or is it the result of a long-term relationship that CHET has built beyond this project itself? Or, what are some of the elements? Because I think that is one of the critical things that, as has been said, these partnerships make the services more available, more efficient, etc., but they're often quite challenging. And then one specific question I had was about the concerns that were raised about the Dilaasa staff being perhaps in more precarious contractual situations and remuneration. And is there any potential for getting more government support for the staff, or would that sort of change the dynamics and the relationship? I have a lot more things that I could say, but I'll just stop there. Thank you. And congratulations, everyone.
Does Sangeeta or Sanjita, one of you want to answer?
Yeah, I'll quickly jump in, and I can see that Dr. Malik is here, and she is the veteran who initiated this 22 years ago. So really glad that you're here. Quickly it's hard, Claudia, to summarize what worked as far as the partnership is concerned, and how has it still been in place 22 years since. I think the entire identity for Dilaasa, the identity was that of Dilaasa, a department of the hospital. So there was neither a CHET nor a BMC hospital, but it was a subsumed identity of a hospital-based crisis intervention department, where all of us reported to a single authority in the MCGM. And I was one of the first people, and I'm sad to see that Padma is not here, and Dr. Malik was our reporting supervisor. So I think it was, in a sense, merging of identities. All the materials produced for Dilaasa were jointly reviewed by both teams. Same was the instance as far as the content of training, handpicking of trainers, all of that was concerned. So to me, I think what took primacy was the transparency of the entire operations, and to very clearly understand that in 2000, when CHET collaborated with the MCGM to set up its first center, we were very clear that Sehat is not going to be running 2,000 centers across the country. We were keen to design a model that is adaptable and sustainable, and that it will be handed back to the municipal corporation. So it was with that thought that the entire PR machinery, the media, all of it was really always, I would say, handled by the administration of the hospital. And these were some of the elements that really helped to, in a sense, make success of this partnership. Yeah, thank you.
I wanted to say.
Thank you. Sorry.
Yes, Dr. Seema, please go ahead.
See, listening to everything, the staff is not paid well. There is funding problem. Gender mainstreaming will only happen if there is gender budgeting. And this gender was introduced something like 12 to 15 years back. But nobody has actually understood what is gender budgeting. And that is why the government officials, they should also know what is gender budgeting, because the planning commission says you should have gender budgeting, but here no one knows what is gender budgeting. They are being trained, they don't know what to do. So here we have to do some advocacy about the gender budgeting in all the government departments, actually health system. There is gender budgeting. But if the same budget, whenever the budget is produced in front of the higher authorities, never gender budgeting is being given any importance. If we can show how the gender budgeting can happen and where we can introduce the one-stop crisis center for the women, and so that and women-friendly hospital, naturally gender mainstreaming will happen. It will be one part, or I can say one way of gender mainstreaming. That's what I think, because these 11 hospitals or 11 places, we have suffered the funding, right? Every time we cannot get the funding from outside. The government has to fund for the training, for everything. Because if government planning commission has already said that there will be gender-based budgeting, so why we should not do? Somebody has to advocate. I think NGOs have to advocate. Sehat, Dilaasa, we can give the details how, because of the budget, you could do something. Thank you.
True. Yeah.
Any more
Sanjita,
questions or any more comments from the participants?
I think we are losing participants now because
Yeah, it's already
the timeline was 6:30. Yeah.
Yeah, we can
I just
close.
want to,
yeah.
I just want to reiterate two more points which have come up and which also, in a way, the last two people have spoken about. You know, when we initiate a pilot, if our vision is only for the intervention as a pilot, we will not be really successful. And the Dilaasa model also shows that. Elizabeth said, when piloting, you must plan for scaling up. And that is what Dilaasa did. In the words of what Sangeeta said about, you know, when you partnered with BMC, you went along with the framework that BMC worked within. And your supervisor was the one to whom you reported and who was the face of the project. I think whilst being a critical partner, Dilaasa has also demonstrated that to work within a system, you have to be able to adapt to that system in order to be integrated into the system. This is a lesson which I think all organizations working on sensitive subjects such as violence against women need to learn. I wanted to reiterate this before we close because it's not been an easy journey, but it's been a journey, I think, where a lot of learning has happened and a lot of forward movement has happened. So congratulations to the Dilaasa team, to the Sehat team, and all of you who are here today, and those who are also not, like Padma and various others who are not here today. Thank you for inviting me.
Thank you, Dr. Surinder. Thank you, Liz. Thank you, Mary. Special thanks to Mary because she has joined so in the early hours. It's almost around 6 o'clock at her place
in the morning.
It's a little why I'm not at my most coherent.
Thank you. Thank you to all the participants for joining us today. I have shared the link of the report in the chat. And please contact us. You can write to us if you have any more questions about the report. Thank you. Thank you, everyone.
Thank you, Sanjita. Thank you, Sangeeta, all of you.
Thank you. Thank you, Dr. Surinder.
Thank you. Bye-bye. Bye.
Bye.
Thank you, everyone. Thank you.
Thank you.
Thank you.